Frank, if I ask you to think outside the box a little bit, we did the easy stuff, the BRAF, the tyrosine kinase, the immunotherapies. From an oncology perspective, are there other things we need to think about? I mean, are cytotoxics really dead in this disease, or combinations? What should we be thinking about?
Right. You know, it's interesting, Mike. I think, first of all, like Eric alluded to this, and so did you, about clinical trials. So we should always be thinking clinical trials, because we're never going to be able to answer these questions unless we put people on clinical trials. So I definitely want to put a plug in for that. But what do you do when you give patients agents and they progress through both of them? Adding mTOR inhibitors like Marcia and Eric have done. The importance of sequencing is definitely needed, because we really don't know what the right sequence of these drugs, like they have studied, let's say, in renal cell carcinoma. In my own experience, I have occasionally used cytotoxic chemotherapy drugs. I've found a combination of gemcitabine and docetaxel to be somewhat effective. It's used in other cancers. But it would have to be someone who has a very big disease burden, who can't get radiation therapy or management of symptoms, or cannot get a tyrosine kinase inhibitor of any kind, when you petition to the drug company and the insurance isn't going to cover it. We also have data from our own institution where we, in waiting for upcoming trials with TKIs, talk to the sarcoma people, and they have a nice oral combination of oral Cytoxan and oral mTOR inhibitor, rapamycin. And because the mTOR pathway is active and the Cytoxan is non-cell cycle specific, we found some responses. We actually published our data in a handful of people. So there may be a role in that realm. And the nice thing about that combination is it's very well tolerated. So I think there is room for thinking outside the box, but I think we need to exhaust all our standard measures first.
Yeah, we've come a long way. As we finish up here, I want everybody to have at least a couple minutes to just give some closing comments. What main teaching points, main things, something you just want to share before we close. Dr. Sherman?
I think the thing to always put out is that, unlike a decade ago, we definitely have drugs that work in thyroid cancer or in metastatic RAI refractory thyroid cancer. I think we always have to think about when we're going to start those drugs, and we have to understand how we're going to do in terms of dosing, not start a low dose trying to make a person have no side effects. At the same time, you don't want to have a person on a high dose with a lot of side effects and never make a change. So there's a lot of things that have to be considered when you do it. But still, even though I think that we're unbelievably light years ahead than we were a decade ago, we need to think about clinical trials, and that there is still a lot further that we have to go in thyroid cancer. There's a lot of interesting drugs that are available. And even thinking about the drivers of what's going on in the thyroid cancer cell, while we always talk about BRAF and RAS, there are rare mutations out there where there are things called basket studies that people can take part in. So ALK translocations, I haven't seen one of those, but you definitely have patients out there with it that have responded to ALK inhibitors. And there are other mutations that exist where there are very interesting studies that are targeting that mutation. And those tumors, or those patients, will have opportunities that are beyond regular thyroid cancer. So you always need to think about what else might be available, what are the studies that are going on, and and I think that's I think always have to approach the disease that way.
Forward. Marcia?
Yeah. So I guess I want to add one thing that we haven't really hit on, but I think it brings together a lot of what we've talked about today, is the fact that building on what Eric said, we are 10 years ahead of where we were 10 years ago, where it was almost a no-brainer, as Frank said. They came and you said, "I have nothing for you," and then, or we gave them chemotherapy and you guys all hated us. So we're 10 years away from that now, where we now have two FDA-approved therapies, but we have probably another 10 clinical trials showing efficacy of other agents, if not 20 at this point. And I think that what we really need to emphasize is that thyroid cancer's patients, as much as possible, need to get to a center of excellence, because this is a rapidly moving field. There are doctors who, if you're not really focused on thyroid cancer, you'll never be able to really offer, I think, what is really becoming, I think, cutting edge. And, there's probably about 10 sites across the country where we really focus on these cancers. And I think that, since so many of the times we can give them a bottle and they can come back several weeks later after the initial, phase-in period, it actually, I have a patient coming from Brazil next week. So it actually is not impossible to have people travel for this. They don't have, they can be, you can partner with a local, even a primary care or an endocrinologist. So I think that, you know, we're really making such great strides, but if you're not getting to a center of excellence, and I think that if you're a community doctor who's dealing with this for the first time, don't deal with it alone. Even seeing somebody at, you know, Sloan or, you know, in Texas or Michigan, you can get really great input, and then you can get guidance on how to give these the most effectively. Because I think all of us at all the centers are more than happy to help the local community oncologists, but you really want to know that.
Very good. Naifa?
Yeah, I think that you know, we need to do more research. We need more funding in this area to be able to answer the proper question and, you know, start thinking, let's biopsy these patients at time of progression initially, try and figure out what's happening to the tumor, what therapy is next, thinking about sequential therapy. And I think, you know, tissue is going to be the issue, and addition is, you know, thinking about personalizing the therapy, you know, what is right for this patient. Stop thinking about differentiated thyroid cancer as one big disease, right? This is not just, even by histology, Hürthle cell, follicular, papillary. This is going to be molecularly based and very individualized and at different time points within the same patient. And doing more research in terms of patient-reported outcomes. I mean, we recently looked at medullary thyroid cancer, which is different, but the patients who are about to be started on cabozantinib look like stage 4 lung cancer patients, and we keep calling these patients by physician-reported outcomes as asymptomatic. So just thinking about that. And then don't forget about local therapy. So even if the patient you think needs systemic therapy, maybe they might need a bone met, you know, radiated, or a metastatectomy, or something done for local things, so don't forget about that. Or hold the drug, do some neck surgery because of central disease, and put them back on the drug. And then, the last thing I want to say is, let's not tell our patients that if you had to have a cancer, this is the best cancer to have. Not a week goes by without a patient telling me they were told that. It's very sad.
Absolutely.
Yeah. I think going back to what the panel has said here, I think we can't underestimate quality of life. And we're looking for targets, we're looking for treatments and sequencing, which is all important. But at the same time, we need to take into consideration that none of us are taking these drugs. We're prescribing them. And that it's important that we develop these relationships with patients and their families to ensure that we can make this into a chronic disease, but that quality of life is really important. In the decision study, there was very nice quality of life data that shows that it does drop off, but it can be maintained. And I think we need to find mechanisms, you know, to do that, and we need more studies in that realm as well. And I agree with the personalized reporting. There's a data from a head and neck cancer study where patients report their data as compared to what physicians perceive the data, and the interesting difference you can see in that side effect profile. And I think that the Centers of Disease Excellence, I know in head and neck cancer patients as well, there's now published data saying that patients who are seen at Centers of Excellence or large academic centers do better than patients who are seen in the community by an oncologist or perhaps an endocrinologist who doesn't see as many patients as we see. So I think emphasizing that to our medical colleagues is very important.
Thank you very much. This has been very helpful. We've covered the whole range from diagnosis through RAI refractory, and I think we've really sort of touched on a lot of the difficult issues that we deal with in clinic, that it's really hard to implement some of these guideline standards, but we're clearly moving in the right direction. On behalf of our panel, we thank you for joining us, and we hope you found this OncoLive peer exchange informative and useful toward future practice.